Namaste, good evening, and a very, very warm welcome to all of you to yet another safe session. Thank you so much for being on time, and we hope more will join in due course of time. I'm requesting all of you to stay muted and also keep your videos off so that the session is not disturbed. Okay, please do not unmute your system. So just give me a second. I have few slides to share before I invite today's ANEI Patient Safety Fellow to do the presentation. One second. Can someone confirm that you can see my
Yes,
slide?
ma'am, we can see you.
Okay,
Yes,
great.
ma'am.
Yes, ma'am, we can see.
Thank you. So, safe is safety awareness for excellence. So, this is a monthly learning session, and in September, we did not have one because of the conference we had in Guwahati, a very successful and annual ANI patient safety conference where we had more than 500 people attending for 1 day of conference. It was very well attended. And so we have two sessions in October. So you will have one now, and then the next one will be at the end of the month. Before we start, I'm going to play the anthem, any anthem for all of us, and we can, wherever we are, we can just stand in respect to the anthem. So, ladies and gentlemen, this is our Association of Nurse Executives India's anthem, and this is available on the YouTube. You can always find for any function we would like to start the function with that. Just give me a second. There are people waiting in the waiting room. Let me just add them. So, Amita, are you there? Amita,
Yes, ma'am.
I'm going to make you co-host. Can you please take care of admitting people while I am talking? Okay. Hello.
I'm muting. Yes, ma'am. Can you hear me?
Yeah, I can hear you. Just admitting people,
Okay, ma'am.
so that I don't have to, because if when my slide is on, when I start admitting, there's a problem.
Right,
So,
ma'am.
Mohanan, please mute yourself. Requesting everyone to stay muted and stay off the video so that we are not disturbing the functions. Okay. So, welcome back, all of you. So, this safe sessions are brought to you by ANEI Patient Safety Fellows. This is the fellowship program that we are having every year. We induct a cohort for 2 years, fellowship program, and this is being done in collaboration with Patient Safety Movement Foundation USA. And the fifth cohort is what is getting inducted this year. So every year we do have a commitment to have a monthly learning sessions. So this year we started with the SAFE series, Safety Awareness for Excellence, and we have held all of them. And September, as I told you earlier, we did not have it because of the conference. So in October we'll have two of them. So today you'll be listening to reducing hospital acquired pressure injury. So this is a project, capstone project, done by our fellow. We'll come to that in a minute. So cohort 3 is the cohort that completed their program from 2023 to 2025. Their photos are on the screen, and one of them, Miss Nitu, is the one who is going to present today. So all of them have done some session or the other throughout the year. And this is cohort 5. This is this year's cohort. We have increased the number of, fellowship applications from 7 or 8 to this time we have 13, senior nurses who are joining us, and even we have younger ones also in the cohort. And on 14th of October, that's next week, they will be formally inducted into the program. And also, Dr. Michael Ramsey, who's the CEO of the Patient Safety Movement Foundation, will be joining for this orientation. So, it's a very prestigious program being run by Association of Nurse Executives India. This year's chance is already over. So those who are wanting to do this fellowship program can wait for next year's announcement, because the joining of the new cohort happens in September. So we usually start asking for applicants, etc., late July or early August. So, welcome to the cohort 5, whoever is present here, special welcome. So, today's session is presented by Neetu, and as I told you, she will be presenting the capstone project that she has presented, because that's a project every fellow has to do when they are doing the fellowship program. That is one of the requirement. So, Neetu will be speaking on that. And on 30th of October, Anuradha Bhatta, she is the cohort 4, 2024 to 2026. She'll be speaking about innovative approaches to pain management. So, with that, a little bit of information on the Patient Safety Fellowship Program and what we are doing is shared with all of you. And all safe sessions, they get recorded and they get uploaded on the Annie's YouTube channel. So, if you want to see the previous ones, you can always visit the YouTube and you can learn from any of the sessions that we have held so far. So, thank you very much for so many people being here on time. So, Neetu, a very, very warm welcome, and I hope your system is working and you can share the presentation. Can you share the presentation?
Ma'am, good evening. Actually, suddenly my network is dropping, so I can't share the presentation, but I connected through my mobile. I request you, I have shared the PPT with you. If you can just share on the screen, ma'am, while I can talk.
Just a second, just a second. Just give me a second.
Sure.
Amita, you can keep admitting people. It's asking for a password.
Ma'am, you could put the password is. I'll just share with you.
Huh? Okay,
I'll just share. I'll just share with you.
okay. Sorry for the glitches. Participants, apologies for that delay. Just give us 1 second. Technology can fail us at uh, the right time. So let me put the password and get her presentation up.
So meanwhile, ma'am is sharing. Really sorry for the delay. Suddenly the network is dropped down, and I tried my level best to connect through the laptop, but it is not happening. So further, before we start with the today's presentation related to the project of healing, like which is majorly the part of the patient safety. As a being a patient safety fellow, routine whatever we are having at the bedside,
Can
and
you
what?
see, Nitu?
Yeah,
Your
ma'am.
presentation is
Yeah.
up. Okay, you just have
Okay.
to tell me next, okay?
Sure, ma'am. Sure. Okay, thank you so much, ma'am. So, a very warm good evening to everybody present over here. So, I'm Nitu, cohort 3 fellowship from the cohort 3 fellowship program for the patient safety. So, here I'm presenting my project on the pressure injuries, that is hospital acquired pressure injuries for the improvement and the patient care with identifying pressure injuries at early signs. So, before I start over the things, my humble gratitude to the people who allowed me to do the presentation. Before that, the project has been successfully done with the help of the team over the hospital and the patients who have improved. So moving forward, ma'am, can you next slide, please? So seeing the background of the study, so hospital acquired pressure injury is one of the significant global health concern, and millions of patients like annually getting into this affecting annually and leading the increased morbidity which is extended to the hospital stay and also the higher health cost. We know that the patients admitted with further disease condition and because of any negligence or patient condition where we are restricting the movements that can lead to the pressure injury. Our happy is the highlight of the urgent need for the effective preventive measures and the management strategies. So despite of advancement, still the pressure injury remains a critical challenge for everybody to understand, and it is important to continue the research over it. And this project actually I have done in my previous organization in Rajagiri Hospital, where we have done an evidence-based approach to apply for the better outcome of the patient. Next, please. Am I audible? Ma'am, next slide, please. Actually, ma'am, my slides are having a little bit of effects. That's every single click it is coming up. So coming to the problem statement, the major problem concerns which we have dealt with is the high incidence rate, which was almost about 0.67 per thousand rate due to the long duration surgeries. One of the major challenge for all the tertiary care hospital, where the surgeries go sometime beyond the 6 hours and the patient leads to developing pressure, not a pressure ulcers, but the initial stage of happy, that is grade 2, where they develop some sort of skin rashes, the redness over there, and also which will lead to the due to the prolonged bedridden cases that risk was there. Coming to the inappropriate assessment, one of the challenge for every hospital is attrition, where we are getting the new people on board. and where we found that the inappropriate assessments in the initial stage because of lack of knowledge and the training and the monitoring, which it increased the cases about 55% of record. Inadequate knowledge is also the awareness related to the risk assessment and prevention of pressure injuries found to be 60%. I request the participants please mute themselves. So when we deep dived into the analysis of pressure injuries, we found that there are majorly the three reasons. With the help of Pareto chart, it has been found 80% of cause of happy was long hours of surgery. There is why 31%. Restricted mobilization due to the patient condition sometimes happens. It is 26%, and the gaps in the effective nursing care found to be 21%. Next slide, please. Project team, the champion for the project is one of my ICU supervisors, and the different team mentors who have been helping me to do the project. Next slide, please. Coming to the focus on the objectives. So there are three objectives which we have actually focused upon. First is the reduce the incident rate of pressure injuries, that is below the benchmark, which was defined on the basis of National Pressure Injury Advisory Panel. The benchmark for our hospital at the defined year was 0.36 per 1,000 IP days. Second was the objective is to increase the awareness and the knowledge of the nurses with the protocols for more than 90%, where we have implemented different kind of evidence-based practices and the pathways to follow up, which we will discuss in further slides. Accuracy of identification of high-risk patients is to be improved more than 90%. So it says that if you check on your patient, identify the patient at earliest, we can prevent the issues. Next slide, please. So coming to the story of Happy, the pre-study.
Just a second, Nitu.
Yes.
139656, please mute yourself. If we find that you are unmuting yourself multiple times, we may just remove you from the session, please. Please respect the decorum of the Zoom webinar. Okay, there you go.
Yeah. So as for the Happy story, there are the phases were divided into pre-study and the post-study, and in between the implementation was done. Where the pre-study, the reduction was expected to be 50%, and the post-study we actually have been got that benchmark been done. In view of occurrence of raise of incidents, we have team has decided to do a quality improvement project where, as is mentioned in the objectives, that 0.36 per 1,000 days was the target for us. Next slide, please. So here's this Happy implementation has been started. So first of all, as I mentioned, if you remember in my Pareto graph, there was almost the first utmost cause was the pressure injuries developing due to the long hour surgery. So where we found during the analysis that most of our devices were not appropriate. So replacement of OT support devices was the first thing which we have focused upon. Introducing the prophylaxis dressings as well. So where we have applied the dressings before the patient is going on the table to prevent, like where we know that it is kind like the next, the third point, which says that the Scott trigger risk assessment tool. So it is kind of a tool like we are having a Braden scale for the patient who are admitting in the hospital. Same way the patient who are going for the surgeries, we are actually doing this Scott trigger risk assessment tool to analyze the patient as any risk while at the OT table to develop any kind of a pressure injury. So this Scott trigger is basically, there are a few parameters which was been involved, is majorly considered to the patient age, the patient weight, as well as the hour of surgery the patient is going through. So where it helped us to understand whether the patient will have the risk or not. And on that basis, we are applying the pressure injury preventive dressing items. So that if the patient is on table also, if for the long hour surgery, it has actually helped us to prevent the pressure injury in initial stage. Second was the issue was usage of pressure injury relieving mattresses, restriction mobilization, where we have focused on protocols to use the pressure relieving mattresses if we are knowing that the patient is coming up with the post-surgical procedure and the patient is going to be on bed for a longer duration. We are preferring to have the pressure relieving mattress, and this mattress are also being defined on the basis of the weight of the patient. So is the patient requires the active 3, active 4, or active 5, nimbus bed, it has already been decided on the patient weighing what is the weight of the patient. Pressure injury prevention and management trainings, where we are following the asking bundle, pressure injury protocol release and implementation. So here we have actually compiled all the pre-assessment for a patient who are going through stay in the hospital and through the care the patient requires when any kind of a surgery is happened to the patient during that. Third thing was the gaps in the effective nursing care. So where we our specialist nurses has been very much helpful for us. That those are our tissue viability nurses who are doing a bedside training, as well as they also helped nurses to monitor the nurses whether they are performing fine or not. Introducing a tissue viability nurse was a catalyst between the training and the implementation, definitely. But the role of managers in the bedside was very much important, because training them, making them sure that the things had been followed 24/7 in the department was the one of the biggest factor, changing factor in our case. Point prevalence audit for the pressure injury. So in the day, it was been like almost 335 patients has been audited for the pressure injury. Then we went for the preparing a care pathway. So as I mentioned, the journey of a patient inside the hospital, starting from the assessment till the patient discharges, what all the care the patient supposed to go through was being defined in that care pathway. Then the other initiative, which also will help us to random audits by the tissue viability nurses, introducing appropriate quality and the size of the dressing, and inter-rated auditor, inter-rater auditor for the pressure injury risk assessment tool was also been implemented. So different audits actually gives you whether you are going right or wrong, or any other implementation or the change in your training is required or not. Next slide, please. Okay. So these are the few glimpses which I am talking about. The selection of support surface, like on the basis of the patient weight, the defined which bed supposed to be given for the patient for the exact preventive. Because it's not only applying a pressure injury relieving mattress is enough. Sometimes you have to make sure that you are applying the right pressure relieving mattress according to the patient weight. Coming to the usage of pressure injury relieving mattresses, this is the OT devices, the pressure preventive devices which we've been used. There is a prophylactic dressings are also being implemented, as well as the dressing was also implemented afterwards. The good part of the dressing was it is not required to change on a daily basis. Then we also displayed the care pathway in each and every department so that the nurse can follow it properly. And last is my Scott trigger risk assessment tool, which we implemented for OT patient assessment, risk assessment. So how we have achieved this improvement, the things you have seen that it was an aggressive implementation of the different aspects where we have actually been achieved 62% improvement in our pressure injury reduction. So we have targeted for 50%, but it went very well, and the things were implemented in a very smooth way with the help of the team, which actually given a better outcome. Next slide, please, ma'am. Coming to the other objectives being defined, the knowledge of the nurses, which we found that improvement of 36%, where the accurate identification of high-risk patient was also improved with 44%, and the impact of the patient satisfaction. So when your patient is going rightly with the proper care, of course, the satisfaction score will definitely impact. It is not directly, but indirectly, where because pressure injury is one of the factor or one of the indicator for the nursing care. Okay, ma'am. Next slide, please, ma'am. So this is the success story. So patient admitted with the pressure injury, cured pressure injury inside the hospital, and patient also developed longer surgery where the skin rashes and uh, blisters has been formulated, where the cure with the proper care has been done for the patient, and patient went without the pressure injury. Next slide, please, ma'am. So the way forward has been implemented over the after the project was like it has been discussed for the planning implementation to done in a complete hospital, because in this particular project when we have initiated, it was has been focused in particular areas where OT was one of the area of focus, surgical ICU, medical ICU, where the long term patients, and one of our floor, which is the sixth floor patient, where we are getting the patient after surgeries, was a major focus area in the initial stage. Later, it was being implemented to all the departments. Focus will be on the OT procedures, implementing rigorous risk assessment, regular skin checks, and while utilizing the habit management protocol, which has been continued. And it has been sustained. Plan for developing a management protocol care pathway. It is like a complete set of care pathway where we also plan to categorize the patients into the pediatric populations, where we are putting up a scale of which will be assessing the patients, which is basically the pediatric patients. So with all that references, next slide, please. So coming to the end of my project summary is that this was an experience where we have actually indulged with the different kind of tools and implemented different practices at the bedside. And coming to the training, the focus was different. So here we also wanted our managers as well as the bedside nurses are greatly involved for the patient care. So we divided, even though the training has been the third party training, the third expert party was usually coming for the training. So we have involving them from the initial stage itself when the nurses are getting inducted. One of the initial session has been taken up in the initial stage. After that, it has been continued with the CNEs, which usually happens in a month, 3-month quarter basis, and then the 6 monthly sessions, which is majorly for the leadership or managerial levels, so that the each role should understand what is basically they supposed to do in particular area to betterment of the patient and to maintain that, sustain the proper care. So this project was illuminated our path forward in improving the patient care and preventing the pressure injury developed among the patient admitted to our hospital. The findings have paved the way to target interventions, underlying our commitment to raising the standards of the care critically ill patients. So with that commitment, next slide, please, ma'am. So we are committed to the patient safety. We are because of our patients. So that was one of the greatest achievement, I must say, that the team has been initiated with the proper guidance, and it was really helpful for improving the pressure ulcers, pressure injuries in the hospital, and the reduction as well as the knowledge and awareness was been greatly improved. So with that, I'm resting my slide. If anybody is having any questions for me, can ask.
Thank you, Nitu. That also was a little bit of dash in your presentation. You went pretty quickly. Nowadays, people
Yes.
talk pretty faster. Okay. So we'll wait if anybody has any questions they can ask. And meanwhile, I do have a couple of questions to ask.
Yes, ma'am.
So when you did the knowledge assessment of the nurses, can you recollect what was the domain that they were majorly they were lacking knowledge? What
So,
were
ma'am,
misconceptions?
sure. Okay. So during our, as I said, ma'am, we have done one of the day in a particular audit where we have identified different categories of nurses being like lacking in the knowledge related specifically related to the kind of grading, like which grading of ulcers is this and how it's supposed to be cured. That is before that assessment part, coming to the Braden scale, the parameter related to nutrition and that friction was one of the concern area where we actually not getting a proper scoring by the nurses. because they are not turning up, they are not checking the sheet, that whether the wrinkles are there or not. Because sometimes it's like nobody is watching me, so it's okay, we both can manage. You are my friend, I'm your friend, so we'll just stick it at and we complete it. We also focus that individual checkings are not giving us a better assessment. So what we have done, like as per the risk category of the patient, initial scoring, the frequency of the risk has been identified. So if the patient is coming under the category of moderate to high and severe risk, it's supposed to be done 3 shifts. And if the patient is having no risk or the low risk, we went to the 24 hour, because sometimes over assessments or also give exhaustion. So nurses just stick it like for the purpose of documenting it. And best part of the hospital, like we are implementing EMR, so we can be like monitoring the patient nurses documentation anytime and anywhere. It was very easy sometime to check upon the particular areas which has been selected. Second thing been identified in knowledge lacking is they know things as a theoretical basis, but when it comes to implementing the things, the connection was not happening properly. And as I mentioned to you, ma'am, like every shift we are doing the assessment in that particular time period. Also, what we have done during the handover time itself, the risk assessment tool supposed to be completed. So one, the nurse who is coming in, the nurse which is present, she should check, and other nurse should need to verify it properly. And same thing during the even changing the ward, like shifting from the one department to another department also. Majorly, we focused that skin assessment should be done within 2 hours, because first the patient should be get comfortable. Let you give the handoff and let the nurse come back. In between, while we are positioning the patient, if we are able to check this back, is fine. Else within the shifting of 1 to 2 hours, the assessment should be done. Because sometimes we are shifting a patient turning up, and these nurses will be there standing that this happened in your department, this is not my department. So kind of things were being managed in that way, that patient should not get uncomfortable while shifting. That everybody is just checking on the skin, where is the pressure injury happened, or where is the skin is not clear. So in such ways, actually everybody taken up the responsibility, which I understood. And training also, we have divided according to the category of the nurses. As I mentioned, we also focused on the managers training, which was being done 6 monthly basis, where what is their role supposed to be. Nurses anyway, initially induction time it has happened, and after that monthly on the basis, initial time it was monthly. Every month we usually having a 4 batches where we are 100% we are completing the training. So every batch we are taking the same topic with the hands-on practice on the particular mannequins. And also after once it was sustained, it was went to the quarter training.
Okay. So I think this is kind of echoing of what I have experienced also, is that theoretically nurses may know lot of things but not necessarily in action. I'm very happy that you found nutrition also as one of the gap, and this is definitely a gap in all the hospitals, not only for pressure at risk for pressure injury patient. On overall, how much of attention do we pay to our patients nutrition and hydration,
Right.
until it is specifically ordered by the doctor? This is something that I've been trying to advocate, to say that nurses must know that the diet or the nutrition and hydration is as important as the medicines. Somehow we tend to believe that giving all the medications and the antibiotics on time, sending all the tests and getting all the x-rays and MRIs done, collecting the report, and those things are important, very important,
Right.
but it will not be a wholesome healing
For the
practice
patient.
for the patient. So this is something I have seen as a major gap, even when I have my mother was admitted as a patient. I've seen this because they were more diligent about everything else except the, food
Yeah.
that my mother is eating or not eating, whether she's passing urine or stool. So, but we all have learned Maslow's hierarchy, right?
Mm. We
Air,
don't focus.
air, food, and water. Patient is breathing, saturation is okay. Next should be food and water. But we tend to go immediately to the medications. I really hope the people who are, sitting here and the people who are going to watch the recording will take this one at least as a learning from the entire project that, poor nutrition to start with is a risk factor for the patient to develop complications. They have to heal faster and go home. Nutrition and hydration plays a very major role. That's very important to notice. And the other thing I wanted to highlight was also that when we talk about, I do pressure injury related training across the country on behalf of a company that I'm working with, in my individual capacity. So I do this training in many hospitals across the country. So anytime you ask that, what will you do to prevent? It is almost like a Nara. Two things will come. Turn the patient to hourly and back care. So I don't think I heard back care in your presentation. What you told was skin assessment and skin care. Now it is very important for all of us to realize that pressure injury happens on pressure points. So all the pressure points needs to be observed. So when you do a skin assessment, you're not only looking at the back. Back
Right.
happens to be one of the most frequent sites where you get, you know, pressure injury. So I was asking a very interesting question, and it's open to all of you. Why is it that sacrum is actually the most commonest site for pressure injury? If you look at it, there are no bony prominences in the sacrum, right? Though coccyx is there, but except when you are very skinny and bony, I don't think there is anything that is actually putting pressure like any other pressure points like the heel or the knee or behind the ear or occiput, where the pressure is there. So I was wondering that why sacrum is the most commonest place for pressure injury. Any thoughts on that?
Hello.
Yes, yes, go
Hi,
ahead.
hi, ma'am. Very good evening. This is Kshitija here, and I would like to answer these questions because this is basically as per the National Pressure Injury Guideline. Probability is as a being a nurses, we are keeping the patients is at 45 degree, but as per the guidelines, we are supposed to keep the patients as a 30 degree, and that is why sacrum is the most prominent area wherein even though there is, as you said, ma'am, that there is no more, bony prominences, but there are multiple reasons, and because of that, the patient is getting the pressure injury at the sacrum. Number one is there is uh, our own bed mattresses, which is causing more of a moisture. Indian bed mattresses, the humid climate of an Indian or Asian scenario, and definitely we many of the places or many of the healthcare sectors we are not applying any kind of the prophylactic measures like the prophylactic patches, as madam has already been mentioned. That is a one basic cause wherein the pressure, even though uh, bony prominences are not there, but definitely the coccyx is the area wherein they get a majority of the pressure injuries.
Okay, yeah. Where do you work, Kshitija?
Yeah, ma'am, I'm from the Monleki Healthcare India, and
Ah,
yeah, I'm in the Wondercare since the 2 years.
I was
And I
thinking of,
met I met Madam in 2024, where in the Rajagiri hospitals we have.
oh,
I would suggest that was a fantastic job. The David Madam and Madam Nitu has been, made this project. So we were really appraised in and really appreciated with this project. I've even met Madam Nitu also in nursing conclaves at South. She might have also
Yeah,
remembered.
yeah.
so
Thank you, Shruti.
Kshitija,
I,
thank you, thank you. I think
Yeah.
thank you,
that
ma'am.
has given great insight, and I tend to agree with you. Number one, I have few more points to add. This is from my own practical experience
Yes, ma'am.
with the nurses at bedside and me as a CNO also. I'll add to that. Number one, as you said, when we are keeping the patient propped up, we are not keeping them at 30, but we are keeping them at 45. The higher ankle that you give to a patient, the more shear and
Yes.
friction and pressure we are exerting on that particular area. And the other thing that I have seen is the more critically ill patients whom we actually see pressure injury happening. We do say we turn the patient every 2 hours. Okay, the word is repositioning the patient. So when we reposition the patient, there are multiple things that does not go right. So number one, patient is on prone position. Okay, maybe 30 degree is already achieved. Now I'm going to turn the patient to left lateral. So when I'm going to turn the patient to left lateral, the first requirement is, since the patient was on prone position, there are multiple pressure points which have been exposed to risk. So I'm supposed to be observing all those pressure points to see that are they all okay? Does the patient have pain on the pressure points? Is there any skin changes on those pressure points? So Neetu was mentioning of skin assessment. The intention is to do the skin assessment of all the vulnerable areas, which we fail to do. So usually what we do, turn the patient, customary back care, position the patient. And patient will not be on fully lateral position. You may start with lateral, but then finally they again come back. Their buttocks is still in the supine position. This was a common complaint the intensivist used to tell me. Okay, ma'am, please train the nurses how to position critically ill patient. So we are not actually helping the patient to relieve the pressure from the pressure points, especially the sacrum. So it's a very good idea. Those who are sitting here, when you go to ICU tomorrow, go and see that how your critically ill patients are positioned. Are these at-risk areas actually being offloaded from the pressure or not? And another good point that Kshitija mentioned is the microclimate, the kind of mattress that we are using on the patients, and the special alternating pressure relieving mattresses that we have in the market from good companies. They are supposed to be taking care of the microclimate. That means no excessive generation of heat, and then the moisture accumulation is not there, because sacrum is one area is also at risk of getting contaminated with urine and stool. So your moisture contamination is also very high. So, the more that we understand the reasons for developing pressure injury, the more that we need to think practically, what exactly are we doing to prevent that in that patient, rather than just giving one answer, 2 hourly position changing and back care. So, I used to ask, only the back is at risk? There are many other areas, behind the ear and occiput is probably the most commonly missed, pressure injury sites. So, yeah, nutrition, hydration, we definitely said. So, it's actually a vast topic once you want to get into preventing. I mean, in your capstone project, you have shown a very impressive improvement. That means if you focus, it can happen. And also operationally, I like the idea where you said that if the patient is on low risk or no risk, just do the assessment every 24 hours. Now, the another problem that I have seen when I was in hospital is that when the patient's condition changes, patient may come walking for a surgery, but after surgery, his Braden scale will change, correct?
Right, right, ma'am.
And many times it's the same number that is being followed. So, I think we have to stay away from just doing things routinely. We have to be aware of what we are doing for our patients and why we are doing. Then we will, the all the scores and all the tools will help us, because they are all created to help us to protect our patients better, right? So these are some of the thoughts that are coming to me. Obviously, your project definitely had shown. So the three domains that you checked was, one is the process itself, then the infrastructure itself, and then you looked at the knowledge component of the patient, right? So
Right, ma'am.
It is always good to look at this, like you say, structure, process,
Process now.
and outcome is what the result of what you did. It's always good to look at that. So a fantastic discussion, and I really hope all of you learned something from this session. If any one of you have any more questions or any other comment that you would like to add, we are able to hear that. Let me ask you a very interesting question. How many hours does it take for a pressure injury to develop? Please put it in the chat box. What do you think is the answer? How many hours or how many days will it take for a pressure injury to develop?
Actually, I've given the answers during my presentation too.
Can you please put some answers? Don't worry, we are not going to
Madam.
give you medal or not give a medal. Okay, 24 hours due pressure. Okay, okay, okay. So the literature says it can take less than 1 hour in a vulnerable patient, the right settings. So usually people tend to think it is 2 hours because too early we are turning the patient. But it is not necessary that all patients can survive with that 2 hours. When I was a critical care nurse, I know that you know we sometimes had to turn patients even at 45 minutes, because when we look at the patients, when we do the skin assessment, we know that if we were late by even few minutes, the skin would have suffered. So patient to patient it can happen. I am not saying that every patient is going to develop in less than an hour, but it all depends the condition of the patient, all the risk factors which are available, starting with the height, weight, nutrition, hydration, edema, skin status, moisture, friction, shear. There are many other things. So, and Braden scale is a wonderful tool, but I'm very sure that you must have experienced this in your assessment, that there can be variation. You talked about inter auditor, you know. So
Yes,
what
ma'am.
was your experience? There is a possibility that parent scale, when you're doing 1, 2, 3, 4, whatever number that you're giving, mostly moist, 50% of
Mm,
the active. How does that sound to Nitu and to Tankam? How do you
It can
make
be different.
sure that Nitu and me, Tankam, will do the rating exactly the same way? So one of the things that I learned many years ago when I was in Fortis was that the skeletal Braden scale, where only those titles are there, will not help. You need that expanded version of the Braden scale so that nurses can refer to it and then give
Right.
the correct number to the patients. This is something that I learned when I returned from abroad and I was first time CNO. I realized that, when I cannot remember everything in that Braden scale, how can I expect anyone to remember all that detailing? Because it talks about no this much percentage of food a patient has consumed. You will give
Right.
this number, this moisture, how many times patient is wetting, not wetting. So memorizing that becomes a problem. So it's very important for nursing leaders and administrators to make the process easier for nurses to implement, right? Because they have to be actually working on the patient, turning the patient, etc. Right? So these are some practical things that are coming to my mind. I'm just looking at the.
And some of the questions are there in the
Yeah,
chat
I
box
am
as
trying
well.
to do that.
Yeah. So somebody, Sagrika is asking like tissue viability nurse is what are you are looking. So
Yeah, yeah.
see,
Please, please, please tell that.
so Sagrika, it's she is actually a wound care nurse. So major her role is not limited to the happy, that is hospital acquired pressure injury. Definitely, she's also looking towards Marcy as well as DAPI and CAPI. So HAPI itself is combination of CAPI. CAPI is community acquired pressure injuries. And then we have device associated pressure injuries. Then also we have one of the other indicator, which is one of the major pain for a nurse is MARSI, that is medical adhesive related skin injuries. So her role was looking towards majorly to those patients who are at risk And also, like I was having almost two nurses over there in tissue viability, who's covering uh, 480 patients on a daily basis, not possible, of course. So, but their major area was being defined that surgical ICUs and the medical ICU where the patients are bedridden, they have to go and check on those patients. After that, any patient coming after the surgery supposed to be checked by them. So this is how like they are mainly looking after, and they also have one of the audit tool which helping them to assess the process and its implementation at the bedside. So that was some of the samples being done by them. Is almost we are covering as per the IP days of your hospital. You have to do it. It says in NEBH as well. So we are covering almost 300 plus patients monthly basis. The audit has been done. So that these are the major jobs and the areas they are looking after.
So there
Uh,
is another interesting question in ECMO cases. Not only in ECMO, maybe in some other critically ill patients, the consultants may give an order not to turn the patient. And
right.
now I will go back to Kshitija's answer also. When
Right.
you know that you are not able to turn the patient and patient is at risk, that's the time you have to ensure the surface on which the patient is lying is right. Second, give prophylactic dressing
Right.
in the at-risk area. This is something when I was a critical care nurse, we didn't have all those kind of, gadgets
Interesting.
available. You can put prophylactic dressing. So we simply used to put some foam and whatever that we can get gloved, water
Water
filled
filled.
gloves, etc. Though in literature you don't find any such evidence. So I think the most important thing is now when the consultant says patient should not be, when you know somebody is going for ECMO, one of the things that you need to plan is the how am I going to protect the pressure points.
Right.
So I have come across experience where in patient develop pressure injury, and when it gets reported, obviously we all will ask why. When we ask the question why, the first answer usually comes is doctor said not to turn the patient. That's the answer. So when I call the doctor and ask, did you tell not to turn the patient? Usually he'll say, no, I did not say not to turn the patient at all. I was just telling, let the patient be hemodynamically a little bit more stable. So nobody bothered to understand that what is that stability means when they didn't even bother to ask the doctor. So I'm being very honest. The nurses sometimes they feel very happy that they got this order not to turn the patient. One work less, no. No need to turn the
Yes.
patient. Doctor wrote the order. So why should I turn the patient? So we are not turning back and asking that, my patient is at risk for pressure injury. This is a dangerous order. What can I do? I think with all so much of sensitization and learning, this is something that we should be starting to ask. That's very important. There's also some more light on types of mattresses and prophylaxis. Asking bundle somebody has
Yeah.
already.
Yeah. I have replied to that as well, ma'am. I
Yeah.
have given the full form.
So, pressure relieving mattresses. I mean, see, I will like to take that up and answer on behalf of Neetu. Is that it's just that to do this training for the company that I'm doing, I had to literally read a lot of stuff around pressure injury. So the kind of surface that you use, the best surface that is being recommended is alternating pressure relieving mattresses, not static mattresses. So I think almost all corporate hospitals are using such mattresses only, but you need to make sure that it is working and the correct weight is selected for the patient. This is very important. And on top of that, we put bed sheets, right?
Yeah.
And the bed sheets quality also matters. If you read literature, the quality also matters. What is the kind of quality of the linen that you are using? And on top of that, when your bed sheet is short for that kind of mattress, it looks nice when the bed is made. After 5-10 minutes, the sheet is not there. Sheet is somewhere folded and under the patient. So these are practical issues that we are facing. So it is very important as nurses, we should talk about it to say that the size of the bed sheet should be larger so we are able to tuck, keep it straight. This is harming our patients. The question is, do we have such discussions? So I was looking at a mattress from one of the companies that I work with. So this company is from US. So they told that abroad nurses actually don't put bedsheet on the mattress. So I was actually in their research and development center. So I told, okay, let me lie down and see on one of the mattress without the bedsheet. So I actually lie down and I tried to rub my heel against the mattress. So I could feel that the feeling of rubbing on a bed sheet and feeling of rubbing on that mattress was very, very different. Hardly any friction. But I cannot advocate not to use the bed sheet because I needed more evidence. So I told them, can you get us some more information? So these are some of the thought process. And if one of the neuro centers in UK has achieved zero happy in so many years. So, neuro centers, they may not be ICU patients. I understand that. So, there is a possibility that, they can do better prevention. S-
It's me only.
Yeah, yeah, yeah. Are you using moisturizer to dry skin? Did you answer that?
No, 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 no. So we used to prefer actually the basic ingredient which we are using for the skin was coconut oil. So that was the best thing. I think no paraffin, no any other things which we usually recommended. That was the I think oldest method, but it is the effective method. I even seen in my experience people are applying honey too, but that anyway I will not recommend because it is then further increases another issues. Ma'am, just question to this particular mattress thing, like how they are able to disinfect it, like with every patient, they are not using bed sheets. So like cleaning and all those aspects will be met
So, it will be just like disinfecting our mattress
same way.
because, you have to put the mattress on every at risk bed.
Right.
So if you leave it as part of the bed in every ICU bed, then it is same like that. And these mattresses are supposed to be put directly on the bed, not on
Okay.
another mattress.
Yeah, that also, ma'am, we have defined in one of the table where we have worked with the particular company with the pressure relieving mattresses. So where we identified what are the overlay beds and what are the beds like where you have to remove it because preventing one kind of a indicator, you will develop another indicator. The patient fall chances of fall is more high. So that also one thing which we have identified on the basis of patient weight and what are the overlays you can use. So basically, active three where we can use it as an overlay, but coming to four and going to Nimbus squad, we should apply it like directly. There should not be any mattresses on the bed,
So
normal
the
mattress.
height of the pressure relieving mattress is important. That's why the right kind of mattress needs to be used for the. See, the most important thing is in US, stage 3 and 4 hospital acquired pressure injury is called as a never event. I think this is one of the things that every hospital should adopt to say that our hospital is committed to zero
Zero.
stage 3 and 4. Once you achieve that consistently, the next focus will be how can I prevent stage 2?
Right.
See, we may think that all of us know what is stage 1 and 2. So believe me, sometimes we don't exactly know that stage 1 is happening, and we must know that before stage 1 happens there is something called a damage cascade,
Already been done.
to which the pain is the precursor before the redness happens. So if you don't do pain assessment on the pressure points, you cannot predict that this point is getting sore now.
So,
Yes, when we are sitting like this for a long time, I know that, oh, this place is now sore, so I will definitely relieve the pressure so I don't get into stage 1. But patients who are vulnerable, who cannot tell you that, most of them have multiple, diagnosis and other things, So there it is very important to incorporate skin assessment and pain assessment. It should not be back assessment and back care. It is actually pain assessment, skin assessment, and
it's
skin care.
clear.
I mean, that's what we should be looking at. Yes, turning the patient, you can have help like slide changes, etc. So there are more things.
Mm.
Apply prophylactic patches to prevent. Yes, I totally agree. These are called the prophylactic dressings. From different companies, you can get prophylactic dressings. Sometimes even transparent dressing on pressure points can reduce friction and shear.
Right.
I mean, even if you don't put a, foam dressing, but if you put this preempting that this site can be at risk, you can do that. Okay, interesting question. How to avoid pressure injury during prone position? We are using some kind of materials even though patient developed. Shanta Kumari. Those who have been exposed to, prone position. Okay, push tool is already mentioned. So I do have one. We'll come to that other one in a minute about push tool. This is my practical advice to all of you. Please do not train all your nurses to do push tool. You are setting it up for failure. Only have select nurses. If you have wound nurse or you have a TVN nurse, let them be the one who should be using the push tool to see whether the pressure injury that developed is healing or not healing. No, it's
Ma'am, I
almost,
can add one thing.
yeah,
Sorry, I just disturbing you in between. Same way, ma'am. I do agree with that. You should not train each nurses for the push tool because it is. So we also included the managers, or you can say the head nurses of the department. So it's like alternative days you can put up. You should not require it on a daily basis. Alternative day, and it is easy to monitor by somebody who can be like realistic to the healing.
yeah. So, how to avoid in prone position? You have any take on that? I don't
Right.
have personal
Uh,
experience because during COVID time,
yeah.
unfortunately, I was not in hospitals. So I had only a few patients experience when I was working abroad when we had a striker bed, which is like the bed can be turned like that, it's like a circle. So we just rotate the patient, and those same thing we used to do was to, in a prone position, there are certain pressure points. So you have to put prophylactic
Right.
dressing before the pressure can, because I think the prophylaxis or the preventive measures have to
And the
be
best way.
proactive. We tend to become very active once the patient develops a pressure injury. I think
Right.
that much of diligence, if we do, the moment we recognize that this patient is at risk, I think we can prevent at least 50% of the pressure injuries which are happening today. You can just prevent them just like that. I think,
Th- There is one more method, ma'am. This is basically I'll say to this is we are using in OT. Where like we were into the process of evidence based practice. We didn't got any evidence on this. It is like mini position changing for like mini minutes position changing. That kind of a technique where we are putting up like all of the few people will having a patient and just relieving for a bit of time, taking up the patient for a minute and then moving the patient again. It's like relieving the pressure from the areas. So where you are taking the patient up from little bit of space should be there between the mattress and the patient, and then again you're putting back the patient to the table. This is like we were into the process, but it was not like greatly implemented. But that was one of the plan for
so
sure in the future. We'll see.
micro positioning, Kshitija is
Yeah,
telling micro.
yeah. Micro positioning. Kshitija can
Yes.
make it out.
Yes, ma'am.
Yeah.
For every
Yeah.
second, our position changes. Are they using any wheel charts, bedside alarms? I personally, I don't believe in any of these charts, because if the nurse does not want to do her work,
Hmm.
not do her work, whether you put a wheel or a clock or whatever it is, that is
Should
for all, for third party appeasement. If I am an assigned nurse, I know that 2 hours before my patient was on this position, I can. And usually in the flow chart, we write, whether patient is supine or, left lateral or right lateral or whatever. So rather than having that, prescribing that at 12 to 4, like that, you will turn, it has to be individualized. Unless you individualize the turning, the repositioning cycle of each patient, we will not be able to achieve anything more than we are achieving today, because we are just going by the clock. And patient, every single patient is very different. So some patient may need even more frequent turning than 2 hours. 2 hours
Um,
is the recommendation in
right.
most of the literature, but by practice, I can tell you some patients will need the turning more frequently. We should
Just
try to elicit that.
I'm just wanted to add one more thing. Like today's world, like we are getting few more digitalization over positioning, like whether the position, what was the position of a patient during that particular time duration. So one of the product which we are like in a process of pilot run related to the monitoring of vitals, especially it was a product of VIOS. We are connecting the patient with the ECG. One of the ECG lead was placed. It is like a monitor kind of device which was connected to the iPad, and the iPad is connected to the central monitor. So basically, that was also telling what is the current position of a patient. We have seen in that particular, if you on that particular feature, it shows that whether the patient was in supine position, that whether the patient was in a side lateral position. So that was also one of the thing. They just initiated it. It is not like fully developed, but I think in future we'll definitely gonna get as a digital mode too.
Yeah, I mean, technology will always come handy the
Yeah.
more. But I think I
Right.
personally would say that a nurse's integrity.
That is
So
one of the major factor
patients
we
who
require.
are patients who are like very sick. Anyway, you won't be having 10 patients of same kind, when you have vulnerable patients. Understanding what each patient's risk and then planning something to protect them from that. That is what is most important, I guess. I think more than the presentation, the discussions have been very, very useful
Interesting
and
and useful.
very interesting. Kshitija, thank you for joining and chipping in. Yes, Association of Nurse Executives India has recently created a ANEI special interest group in prevention of pressure injury. So there's a group of 6, 7 nurses who are coming together, and we are planning to do something in the coming 1 year to help. It is actually what we are hoping is we will actually take references, whatever is available, the best practices, and we'll probably convert them into certain standards and objective elements. So hospitals can go for certification to say that they are doing their best to prevent pressure injury. And to prevent, happy is not just the pressure injuries that happen within the organization, it is also worsening of any copy that has come in.
Right.
Patient has come with stage 2 and it progresses to stage 3, that is also a hospital acquired pressure injury. So important to have all these. Maitri is telling we use dosi. Dosi
Yeah.
is what? Dosi.
Dozy is also the one of the monitoring
Is
device.
companies,
Yeah.
one of the company, what ma'am is telling, for capturing the information with vitals, positioning, everything. In our hospital, we
That is
use with the name Dozy.
Okay, okay.
it's a
They are
non-touch
giving all the
technique.
information.
That's a sensor-based technique, so
Yeah, yeah.
Yes,
Got it,
yes,
got it. But I
yes.
think
yeah,
nothing can replace
the manual one.
integrity. The sense of integrity, nothing, nobody can replace that. And with that last thought, I would say that, thank you everyone for showing interest, because it means that we are concerned about our patient, at least all the people who joined us today. Thank you for being here. And I really hope that we all can work towards, zero happy. I mean, if we aspire for zero, at least we will start, reducing what we got today, whatever we have got today. And it's one last word is also honest reporting is also very important. If that
Right.
honest reporting is not happening, how are we going to prevent anything? So, in patient safety, the first and foremost thing that is required is to be honest about something that has gone wrong so that we can learn from that mistake. And in my long tenure of being a nurse, head nurse, staff nurse, and then CNO, one of the things I sadly have come across is when people are trying to hide the events. And that is something that we should never ever condone. It doesn't matter, under our care, something happened. Let's say that it happened. And then move towards finding a solution so that it does not happen again. So, with that
Oh,
last thought, thank you so much, Neetu, and thank you everyone who is in the session for chipping in and giving your, suggestions and explanations. So, Shitija is doing her little bit of marketing also here. Very good.
No, 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 ma'am. I am not here for the marketing. I'm here for the patient support because
Oh,
my
no, no, no.
entire
That's
life
what
has
I.
gone into nursing. I
Okay,
that's
will
sort of
no
fun.
problem.
help them for
No
the
worries,
patient care.
no worries. I totally agree. Simply was making a joke of it.
Thank you, madam. Thank you,
Whether
madam.
it is Malinke, whether it is Smith and Nephew, whether it is SCT, whether it is Arjo, whether
Right,
it
right.
is Striker, it doesn't matter. They all are in the arena to help the nurses to prevent and protect the patient. Now, the nurses have to be engaged with the manufacturers. This is very important. You need to become smart to engage with the company to understand what is their product, what does the product do, how can it help our patient, what is the cost effectiveness. All these things, if we are totally getting engaged with the partner, like any company that you are using, it's very important to get engaged, because this is something I have seen people just tend to leave everything to the company and say, okay, it is their thing and let them do it. That should not be the case. Total engagement is very important. And thanks to all the industry partners like Malinke and Smith Nephew, SCT, Striker, Arjo. I'm just taking all the names that I am aware of. All of them are doing their bit to help the nurses to prevent such harm from reaching the patients. So, thank you, everyone, and take care. And please reach out to any one of us and let us know that if you want to do something more in this area. But definitely, Annie will be doing something around this domain in the next coming year. Thanks, Neetu.
Thank you, ma'am.
For
Thank you, everybody.
that you did that segment of presentation quickly, so we got enough time to discuss. Thank you, everyone. Thank you for staying back and making this session energetic. And see you all on 30th of October again when we talk about different approaches for pain management by Anuradha. Thank you, everyone. Thanks, Neetu.
Thank you,
Okay.
everybody.
Thank
Good
you,
night.
Good
ma'am.
night. Good night. Good
Take
night.
care.
Good
Bye
night.
bye.
Bye.
Bye bye.